Hi, my name is Dr. S, and today we're going to discuss abdominal aortic aneurysm. Abdominal aortic aneurysm is a permanent localized dilation of abdominal aorta that provide the blood to the lower region of the body, and that is the normal abdominal aorta, and that is the aneurysmal dilation of the aorta, which causes the damage or rupturing. It is very important because enlargement may remain silent until rupture. That is the most important part of this disease. Anatomical location, clinical relevance. Um, these are for the surgeon as well as the PGRs that are working in the surgical department. The abdominal aortic aneurysm occur below the renal arteries, like it is shown in the figure. Abdominal aorta carries blood from the heart to the abdominal organs and lower limbs. Expansion weakens the wall of the vessel. Rupture causes massive retroperitoneal or intra-abdominal bleeding. Major risk factors: smoking above 65 age. Male sex is the most important part because 90% of the uh, patient with this disease or this rupturing of the abdominal aorta is male. Atherosclerosis and family history. Genetics might play a key role in this. Mechanism by which wall weakening and progressive dilation happen. Risk factors: smoking, age, hypertension, atherosclerosis causes inflammation and the killing of macrophages and T cells, especially cytokines, the inflammatory cytokines like TNF alpha, neutral factor kappa B. Proteolysis increase MPP activity, breaks elastin and collagens, especially in the male, due to the high um, level of testosterone, which are more higher in male as compared to females. Females have a very important hormones that are protective. Both it protect both the cardiovascular and the abdominal aortic rupturing in females. Aneurysm growth, progressive expansion, and rupture risk. That is the pathophysiological principle. Remodeling, progressive dilation uh, due to the high blood pressure or other risk factors causes uh, the rupturing, and surgical or EVAR required. Clinical presentation: rupturing warning. Possible symptoms are deep abdominal pain, back or flank pain, pulsatile abdominal mass, severe abdominal back pain, hypotension or shock pulsatile abdominal pain occur due to the uh, dilation of aorta or rupturing of the aorta. Surgical emergency: immediate resuscitation, urgent vascular repair required. It might not be delayed because of the risk factor and life-threatening risk factors might occur due to the internal bleeding. That is the most important part: diagnosis and assessment. Uh, First line test for detection and surveillance: measure aneurysm diameter and growth over time. Non-invasive, no radiation is required. CT angiography for detailed anatomy before the repair, like EVAR, shock, iliac involvement, thrombus or rupture features. Uh, if you are planning for EVAR or repair, open repair. Clinical evaluation linked with these: assess symptoms, blood pressure, shock, signs, comorbid conditions, operative fitness, family history, and smoking. This is the treatment overview. Small asymptomatic abdominal aortic aneurysm. It might need surveillance plus risk reduction like cessation of smoking, exercise, and other key uh, aspects. Uh, the second way, if the aortic is large, fast growing, or symptomatic, abdominal aortic aneurysm is fine. Elective repair or EVAR or open surgery required. If abdominal aortic aneurysm get ruptured, emergency repair or resuscitation required. Medical management and surveillance, smoking, controlled blood pressure, dyslipidemia, cardiovascular risk. Encourage exercise as tolerated by the patient, manage diabetes and comorbid illness, surveillance, serial ultrasound, aortic uh, diameter should be measured, rapid growth, assess new pain, tenderness, refer to vascular surgery when repair thresholds reached. Medical therapy reduces the cardiovascular risk but does not reliably reverse and establish aneurysm. Large or symptomatic aneurysm required procedural repair. Stent grafted inserted through femoral arteries exclude aneurysm sac from blood pressure. Less invasive, require suitable anatomy and long-term imaging follow-up. Possible complication like endoleak, graft migration, and reintervention might be needed. If there is open surgical repair, um, aneurysm is replaced by the graft, more invasive but durable. Uh, use when anatomy is unsuitable for EVAR. High early physiological stress require careful preoperative assessment. That is the step-by-step mechanism. Identify the aneurysm, assess diameter, symptoms, anatomy. Choose the method, uh, whether you want to choose the EVAR or open repair. Exclude or replace sac stent graft, excluding flow or surgical graft replaces wall. Reduces rupture risk, pressure no longer expands weakened aneurysm wall. That is the treatment principle. Repair do not regenerate the diseased aortic wall. It prevents rupture by excluding or replacing the weakened segment. Follow-up is the most important uh, after diagnosis. Scheduled ultrasound required, smoking cessation, blood pressure control, cardiovascular risk reduction, urgent review for new pain. After EVAR, imaging surveillance, check for endoleak, assess graft position, monitor aneurysm sac size, re-intervene if needed. And after the open repair, surgical recovery follow-up, monitor graft and wound, assess renal and cardiac status, continue risk factor treatment, long-term vascular review. That is the summary algorithm. The key message, uh, abdominal aortic aneurysm is degenerative, weakening the abdominal aortic wall. Treatment aims to prevent rupture. These are the clinical images of the EVAR or advanced or open surgical uh, processes. That is the summary. And that is the complete summary of